Right. Good afternoon, everyone. My name is Kizzy Hammonds, and I am the program assistant for Illum, the Behavioral Health Center of Excellence. Thank you all for joining today. We will start in a few minutes as people settle in and more individuals arrive. For those of you who will need CEUs or a certificate of attendance, please make sure that you stay with us in entirety of the presentation to receive full CEU credit. Today's presentation is virtual. We have been offering hybrid setups and full in-person trainings. We hope you all can join us sometime in the future for our in-person trainings. For those of you that are wondering, your video and audio are muted during the presentation. You would notice that there's a chat as well as a Q&A on your screen. Commenting can be anonymous. Feel free to enter comments into the chat section. And if you have any questions for the presenter, please set those in the Q&A for us to ask after the end of the, I'm sorry, not at the end, we just discussed that. In its right place for you to ask the question, sorry. We are also recording this event. The recording will be posted on the Illum webpage as well as the social media accounts. Now I would like to present Places for People in Illum's Vice President of Knowledge, Translation, and Impact, Nathan Dale.
Hey, thanks, Kizzy, and thanks, Sarah, for being here today. So in my capacity as VP of Knowledge, Translation, Impact, I'm fortunate to work with such a solid team in planning these webinars to share updates on our best and evidence-based practices for people who are experiencing behavioral health conditions. And as Kizzy mentioned, that's not all we do. We also work with different community partners to support the implementation of different evidence-based practices within the respective organizations. So please do stick around towards the end of the program today to learn more about the ways you can connect with us and to learn about upcoming events. I'd like to now introduce Dr. Sarah Pratt, who is an associate professor of psychiatry in the Dartmouth Geisel School of Medicine and associate professor of the Dartmouth Institute. Her research interests include developing and evaluating rehabilitative programs to enhance functioning and health in people with serious mental illnesses. Now, several of these skills training interventions she has studied have been integrated into routine practice here at Places for People. And so we're grateful to have her with us today and for her to share her expertise with you as well. I also want to acknowledge all the attendees who have taken the time today to prioritize learning about the developments in this exciting field of both research and practice. We're particularly grateful for the support of the Missouri Foundation for Health, whose support has helped us to launch Illum over the past 2 years. And we're appreciative also of the partnership with the St. Louis Aging and Behavioral Health Council, particularly the St. Louis Behavioral Health Network and the Geriatrics Education Center at St. Louis University for their collaboration. So without further ado, I'll turn it over to Sarah. Thank you.
Thank you, Nathan. I'm really honored to be here. My entire career has been focused on developing and evaluating ways to help people with debilitating and disabling mental illnesses to live more meaningful and productive and healthy and satisfying lives. And so I'm thrilled to be able to be here and share what I've learned over these past 20 plus years doing research, which really all started with a very clear focus on helping older people in particular who have a serious mental illness and are not living their best lives due to the sort of long and short-term effects of illness, both their mental illness and physical illnesses. Back in 2001, when I began doing research full-time, my research group was kind of on the cutting edge in terms of discovering the neck, which is to say, recognizing that the mind and body are connected. and really the important role that community mental health providers needed to play in terms of helping people with serious mental illness to address both at the same time. So I'm going to start by, see if I can advance my slide. Oh, I gotta get my cursor. Okay, there we go. Hopefully that's advancing. So I'm going to start by sort of talking about a little bit of background in terms of the rationale for developing interventions, specifically tailoring them for older people with serious mental illness. And then I'm going to talk about a summary of sort of evidence interventions that now have an evidence base, because there was a lot of activity to create and tailor interventions back in the early 2000s. And then since then, there is an evidence base that has been built up. And I'm going to focus specifically towards the, probably after about a third of the way through, on two interventions that myself and my research group developed. And they sort of overlap in the sense that they both address this issue of taking care of people's mind and body, but they're also different in many respects. So I'll talk more about that later. And then I'll finish up by talking about some other helpful resources. My sense from talking to Nathan and the folks at the Loom is that many of the people who are here are clinical providers. And so I wanted to just direct you to some resources that you may find helpful if you're focused on older people. And so with that, I will just dive in. So, I'm going to start by just presenting some background. It's kind of to give the whole talk some context, but I think much of this is not new information for people who have been working clinically in this space. We all know that the population of the United States, we're getting older. The percentage of people who are older is increasing because of the baby boomers. So right now, there's almost 80 million people in the US who are 60 or older. It's about 23% of the population. And then in another 8 or 10 years, the sort of last clump of the baby boomers will age into 65, and it'll add another 45 million people. So, it's a big swath of our population. And so we ought to be concerned about focusing on that group in particular. Unfortunately, what we also know, many of you, is that folks with a serious mental illness, are a real major health disparity group. And most strikingly in terms of early mortality. So this is, this famous Colton and Manderscheid study, which, and this slide is showing a graph that these are data that were collected over 4 years across 6 different states, all showing that if you have a serious mental illness, your life expectancy is anywhere from 25 to 30 years less than if you do not have a major mental illness. And, it's basically telling us that this is not an idiosyncratic finding in one study or anything. This is pretty consistent that this is the case for people with serious mental illness. And why is that happening? This slide, which is from the same study, shows that if you look at the black bar, it's mainly from heart disease. So while suicide rates are obviously higher in people with serious mental illness, that's the white bar, that is not the primary reason why people are dying too young. The primary reason is from heart disease. And, folks who work with this group know that smoking rates are up to, 3 or 4 or even 5 times higher in people with schizophrenia and other serious mental illnesses. The rates of obesity in particular. It's interesting, the rate of overweight is similar to the general population. The US is getting to be a country where almost 2/3 of us are overweight, or obese. But the rates of obesity are twice as high in people with serious mental illness. And that obviously contributes to developing diabetes and being at risk for heart disease. So it's really heart attacks that's causing people to die early who have serious mental illness. The other kind of difference and unfortunate circumstance that people with serious mental illness find themselves in is is much higher rates of institutionalization. And so my group did some work in the mid 2000s looking at nursing home placement in people with schizophrenia in particular. And what these graphs show is that overall, if you look at all nursing home placements, you have twice as great a chance if you have schizophrenia, which is the little stair steps that are green, of ending up over time in a nursing home versus if you do not have a mental illness. Those are the little blue steps. If you look at the graph on the far right, and you just consider people age 65 or older, you'll see that the steps actually kind of line up together. So there's not a hugely greater risk after you pass age 65 if you have schizophrenia versus you don't have a mental illness of ending up in a nursing home. But it's this critical phase between age 40 and 64 that's accounting for this, overall difference, because in between those ages, if you have schizophrenia, you are almost 4 times as likely to be admitted to a nursing home if you're between the ages of 40 and 64. So there's this critical window that we really need to focus on that's, not so much just quote unquote older, it's middle-aged and older, I guess, but definitely the population that I'm sure many of you who are attending this talk are focused on, that we really need to shore those folks up so that they don't end up prematurely dying and don't end up in a nursing home. The rate of suicide, that's, I mentioned that heart disease is really the primary driver of early mortality, but suicide is something that's, much higher risk, obviously, in people with serious mental illness and in older adults in particular. So older men, you can see the statistic that the highest rate of suicide in the US in 2019 was really older men, age 85 and older. So that's kind of scary. And then they tend to use more lethal means. And so they complete suicide more. And obviously diagnosis of mental illness is going to be associated with higher rates of suicide. So, so now what do we have for a picture? We have a picture of people with serious mental illness, high rates of medical comorbidity. So much higher rates of heart disease and diabetes and COPD and other medical problems. Greater risk of suicide. People with serious mental illness are more likely to receive poor health care for a variety of reasons, some of which is their own ability to access it, some of which is, still sort of stereotypes that exist among physical health providers around the extent to which, someone who has a serious mental illness will follow up. It's sort of like, oh, they won't follow up anyway, so I won't give them top quality care. Some of it's related to poverty and social determinants of health, inadequate social supports. But these folks are more likely to be institutionalized and to die earlier. So it's like a doom and gloom picture, except these are all things, that are preventable, actually. So a lot of the medical comorbidity and things like diabetes and heart disease and COPD, they're preventable. Suicide is preventable. Many of these risk factors are things that we can do something about. So that's the good news. And we have been doing things, trying to work on interventions that can address these risk factors. And I wanted to draw people's attention. Folks may know about this guide, but SAMHSA had an initiative during last year, and there was kind of I think it finally came out in print like in the late spring of this year. And so it's this guide that was put together by, content experts and researchers who sort of surveyed the landscape around what are the interventions that have been developing and have gathered an evidence base for older adults with serious mental illness. And so I can send you, Nathan, if you want the link to this, I can send it to you. But people can go on the website. It's available for free. You can download the PDF on the SAMHSA website. And inside, what you'll find is a description of the process that was used to identify the specific interventions that are mentioned and highlighted in the guide. And then also some guidance around how do I choose among these, some examples of programs that have used these, and some ideas about evaluation, if that's something people are interested in. And just, I don't want to spend a huge amount of time on this, but just briefly, what they were looking for was interventions that have been clearly defined and are replicable, that address the sort of psychosocial functioning outcomes that are currently in use in this country, that have studies that back up their effectiveness, and that, that can be implemented with fidelity. And so they identified this set of programs. They reviewed all the studies that are published on these and then ranked them by, is there strong evidence, meaning that there are at least 2 randomized controlled trials? Is there moderate evidence to support this with at least 1 randomized controlled trial? Or is there still sort of emerging evidence? And these are the 5 that were identified in this guide. So, if the question is, what are the interventions that are out there for older people with serious mental illness that have an evidence behind them? Like, these are the 5. And I'm not surprised that they identified these 5. These are the 5 that really have been cooking and were created back in the early 2000s, when there was a big emphasis on, anticipating, we're going to have this huge growth of the population of people who are older. We need to focus on people with serious mental illness. And so 2 of these, numbers 2 and 3, were actually developed by a group of researchers that I've had a lot of contact with from from UCSD, so in San Diego. And then, of course, there's assertive community treatment. Most people have heard of that. And 4 and 5 are programs that myself and my research group have developed. So, so you can see that there's assertive community treatment, and then the other 4 are really sort of heavily based on skills training approaches. So I'm going to kind of take them in those 2 separate chunks. So assertive community treatment, people know has been around for a long time. It's a real team-based model. It was developed as a way to kind of bring together a multidisciplinary group of providers to really support people with the highest needs, with the highest level of instability in terms of maintaining, their residents in the community and maintaining psychiatric stability. And so the idea was, we need to kind of wrap around folks and address their comprehensive set of needs, including medication needs, vocational employment, therapy, housing, substance abuse, et cetera, right? So that there would be this whole team of people that would all work collectively with folks that had the greatest risk for ending up spending a lot of time in the hospital and institutions and so on. And so this model's been around for a long time. And so this group looked at literature, specifically ACT teams for older adults. So there are ACT teams for older adults, and the evidence shows that using this model with older adults has resulted in some of the primary ways in which it's been helpful is initiation of treatment, remaining in treatment for 18 months, and medication adherence. And this just shows kind of a visual of the way these teams are constructed. And so you have the therapist, substance use specialists, peer support specialists, nurses in particular are critical for older people. And really the primary difference between assertive community treatment for general adult population versus older adults is that the psychiatrist needs to be a geriatrician. And the vocational work really kind of expands beyond traditional supported employment to include things like volunteer work. So the kind of classic like hardline voc rehab folks place this high premium on competitive employment, but for older people that would be expanded to include more volunteer work as well. So that's assertive community treatment. And then, the other approaches are more about skills training. And so I wanted to just kind of start off with a case example. This is someone that was in one of my projects. His name's not Robert. I've been a little bit, intentionally, this is not a picture of him. I've been intentionally vague about some of the details just to protect his identity. but you'll get kind of the gist of it. So here's a guy, 56 years old, not working, hasn't worked in years and years, has schizophrenia, just it's been pretty disabling, lives alone in an apartment in New Hampshire, has no car. He really needs to see a medical specialist in Boston to address a problem that, if he only got this problem addressed, we would see a huge improvement in his functioning and his ability to reach some of his personal goals. Has a desktop computer and access to the internet, which may sound like, yeah, of course, but this was from like 2006 or something, so it wasn't a given back then. And so it's kind of like, what do we do? Do we give him a fish or do we teach him to fish? Do we intervene at the system level or more at the person level? And I had a conversation with the person who was just about to go into his apartment and have a session with him. And it was the HOPE session, the Helping Older People Experience Success program, which was in that list and which I'll talk at length about later. And, it involves teaching people skills. It's a skills training intervention. And the person says, well, I'm ready for my meeting with him. And I've done all the research on, the bus he would need to take to get from New Hampshire to Boston, and then the subways and where he'd need to change trains and, how to walk to this office. And I'm going to go in there and give all this to him. And I said, well, hang on, slow down a minute. Does this guy have a computer? Yeah, he's got a computer. Is he connected to can he connect to the internet? Yeah, he can. I said, well, why wouldn't you, help him do it himself, help him figure out how to get on do just what you did, get on the internet, look up the information, figure out how to do it, plan the trip himself. Trip planning and sort of accessing public transportation was one of the skills in HOPEs. And it was the perfect way of using the skills that he'd been learning in his real life. But the inclination and kind of instinct was, and she's a helper. This is somebody who wants to help. I'll do all this legwork and I'll help him. And she then realized when she went in and took a different approach, and it took longer. It took a little longer for him to get to it and get the same information. But he did it himself. He learned that he didn't have to rely on her. He learned that he could do it himself. He learned that she had faith in him, that he could do it himself. And so that's kind of, I'm not saying that intervening at the system level is not a good idea, because of course it is. We have to have systems that support the ability of people to take better care of themselves. But just to say that, the interventions that I've spent most of my time on focus really on empowering people with a serious mental illness to take better care of themselves, to advocate for themselves, to have more agency, to even have the permission to want to live into a better life. So that's just been my focus, so that I put that out there. Okay, and so a lot of it involves skills training, which is just if you want to think about a definition of what is skills training, it's a systematic approach to teaching skills and behaviors. It's based on behavioral and social learning theories. The idea is to teach skills that are learned gradually over time with extensive practice. Just like any of us that wants to learn a new skill, you got to practice it a lot, both in the context of whatever lesson you're having and then more outside the lesson. And so, in this context, the goal is really to teach people skills in the context of a quote unquote classroom that they can then use in their real lives. Skills training has, broad range of applications to all sorts of clinical and non-clinical populations. It's most often delivered in groups, but can be delivered individually. And it really is the technique for people with serious mental illness that has the largest evidence base. Social skills in particular, we think of interpersonal skills that are really necessary prerequisites for effective communication that then are required for all sorts of different domains and functioning. and behaviors that help people achieve their goals. And that includes nonverbal, paralinguistic, verbal content and things like that. As I said, skills training is usually delivered in groups, and there's a real value to the group in terms of getting feedback and input and sort of camaraderie with other members who you perceive as being similar to you and are struggling with some of the same issues. The goal is not to, talk about insight and do check-ins, but it's really to focus on specific skills that you're trying to teach. It's optimally provided by 2 co-leaders using some kind of a pre-planned curriculum. And again, the focus is not so much on the teaching, but generalization to the natural environment that's planned. How is this relevant to people with serious mental illness and schizophrenia? Oftentimes, in particular with schizophrenia, there's premorbid functioning that gives you a clue to the onset. And people who have poor social functioning really end up having a more severe course of illness. As we know, social relationships and social functioning are really cornerstones for other types of behavior and functioning. And people with schizophrenia in particular have rather stable, predictable deficits and skills that can contribute to this worse functional outcome. And about 50 or 75% of people with schizophrenia in particular have trouble with sort of basic conversational or assertion skills. They have social perceptual problems that can interfere with basic social skills. And they tend to be stable over time if they're not treated. But again, the good news is we can train people in social skills and other kinds of skills, and things can get better. People with serious mental illness and schizophrenia can actually learn new skills. They can retain them over time. They can be generalized to new situations. And skills training really can have powerful effects on quality of life, social functioning, number of relationships, et cetera. These are kind of the 4 core principles of learning in skills training. So there's the idea of modeling, and that's modeling from the facilitators as well as other members that can be observed as models. There's the concept of reinforcement. So, this goes back to basic Skinnerian behavioral, if I exhibit a behavior and something good comes out of it as a consequence, I'm going to do it again, right? Positive reinforcement. Shaping is sort of gradual approximation of a skill. So breaking down a skill into parts and gradually achieving successive approximations to that skill. And then of course, generalization is the ultimate goal. So all of the, most of these skills training interventions, and I'll get back to the other 4 that were on the list, they have some element of establishing some kind of a goal, right? That serves as the purpose and the end game for learning the skill. If you don't anticipate that there's going to be any positive consequence of learning a skill and working on it, you're probably not that invested in it. There's a lot of repetition with people with serious mental illness. So learning and then reviewing, practicing by setting small objectives that will then be in service of a larger goal. Establishing the rationale for the skill, breaking it down into steps of a skill, practicing during sessions, so during the learning time, but then also finding ways to practice outside the session so that generalization will occur in the natural environment. So going back to the list to get back to like sort of what's out there and what's been proven effective. So CBSST is cognitive behavioral social skills training. This was spearheaded by Eric Granholm at UCSD in San Diego. And he's a neuropsychologist, and he was interested in sort of looking at, what if we kind of combine some cognitive strategies with social skills training? Will that help to improve functioning overall? And so he has this manualized, standardized program There are 12 weeks of unique content, and the way he's evaluated it in studies is that he runs through the 12 weeks and then literally starts all over again and runs through it again. And the purpose for that is really the benefit of repetition. And it's 4 weeks of cognitive behavior therapy. He has this catch it, check it, change it kind of little approach where people are taught to identify thoughts or ideas that maybe don't match up with what other people are thinking or are somehow causing problems. And then sort of checking it out, well, I'm having this thought or this thing keeps happening to me, and maybe I should think about it some more and check it out. And then think about a plan to change it. So maybe it's changing the way I interpret something. Maybe it's changing my perspective on something. Maybe it's changing my behavior in some way. And then there's 4 weeks of kind of basic social skills training that's pretty rooted in, really, I consider kind of the grandfather of social skills training for people with schizophrenia is Bob Liberman, who is at UCLA and devised and prepared these really snazzy manuals and modules that were very popular in the late 90s and early 2000s. And so a lot of these subsequent skills training programs have been modeled on that, but so basic conversational skills and things like that. And then there's 4 weeks of problem solving training, and there's this acronym SCALE: specify, consider possible solutions, assess the best solution, lay out a plan, execute and evaluate the outcome. So it's sort of your classic problem solving, figure out what the problem is, think about ways you could solve the problem, what are the pros and cons of each solution, pick one and evaluate how it goes. They more recently, this group developed what's called mobile assisted CBSST. This was an effort to, it's a little bit of like, oh, we gotta have our technology, jump on the technology bandwagon. They've got this handheld personal device that is like text-based. It prompts you. It has components of what's in the program, but on your device, and pushes some self-monitoring tools and things you can track. And the idea was to reduce provider contact from a 2-hour session once a week to just 1 hour once a week. And so there's been a number of studies, there's strong evidence that supports this intervention in terms of independent functioning in the community and skills acquisition in particular. And this is just kind of a visual. It shows that there are group skills training sessions and also kind of goal setting sessions within each one of these 3 different areas: cognitive skills, social skills, and problem solving skills. That's kind of CBSST in a nutshell. The other interventions that come out of the group at UCSD are FAST and PADAL, and they're basically the same. PADAL is the adaptation for Latinos, and not just let's translate into Spanish, but they actually really worked hard to make cultural adaptations to the program. So it's essentially focused on skills training in the areas of medication management, basic social skills, communication skills, sort of organization and planning, transportation, and financial management. And it's a 24-week program that targets all of these areas. It's been delivered primarily in groups and has been shown to have statistically significant improvements in people's functional capacity, symptoms, social and communication skills, and some emergency service use and medication management. So, and then there's the cultural adaptation for Latinx. Okay, so that's that intervention. And then I'll just quickly introduce the 2 interventions that I'm going to spend more time presenting, but just kind of the Cliff Notes version, you have integrated illness management and recovery. It's based on and adapted from illness management recovery, which people may be familiar with, but it integrates self-management training for both mental and physical health conditions. It's provided by a non-medical professional, and there are 10 modules. They're sort of similar to the topic areas that are included in IMR, which I'll go into a little bit more later. And they are delivered over anywhere from 4 to 10 months because there's the flexibility and ability to tailor it either to an individual if it's being delivered that way, or a group if it's being delivered that way. And primarily, we saw improvements in psychiatric and diabetes self-management, hospitalization rates in the IMR group versus a control group, COPD self-management, and community functioning. And then just the Cliff Notes version on the HOPES program that's helping older people experience success. This was a project that started in the early 2000s. It is a skills training curriculum that's broken out into 8 different topic areas. We actually studied the first 7. The 8th topic, intimacy and dating, is something that we've added more recently. But you can see there are topics that relate more to psychosocial functioning and topics that relate more to how to manage and take care of your physical health. So there's, communicating effectively, keeping friends, and so on. But then there's healthy living, using medications effectively, making the most of healthcare visits. So there's a blend of those 2 different domains. It was delivered in groups weekly for 12 months. There's nice manuals, and I'll show you some examples of those, and participant handouts. It also was delivered one-on-one in another study that we did, so it can be delivered in groups or individually. And we had significant improvements in all sorts of areas: psychosocial functioning, independent living skills, quality of life, communication skills, symptoms, health self-management, et cetera. And what was really cool was that we looked at it. We had a 3-year follow-up point and found that all of these improvements held up over 3 years. So that was pretty impressive. All right, so I'm going to go into a little bit more detail about HOPES, and then I'll take a breath and see if folks have questions. So HOPES was originally developed in 2002. We ran a study with, there was a randomized controlled trial in 3 different community mental health centers, 2 in Boston, 1 in New Hampshire, with 183 people who had to have serious mental illness defined as either a schizophrenia spectrum, major depressive or bipolar disorder, and also functional impairment. And so the study went on until 2007, and then we developed an individually based version that was tested later on in another multi-site trial. HOPES has been implemented in multiple US states and in Canada, and it is currently actually being compared in a comparative effectiveness study. It's being compared to cognitive enhancement therapy, which is essentially social skills training plus cognitive training, and more sort of cognitive remediation versus Eric Granholm's model of CBT. And this study that actually Places for People is involved with, and I'm a co-investigator, and Nathan Dell is a site PI, will enroll people with a schizophrenia spectrum disorder across 26 sites. And the sites are assigned to either deliver HOPES or CET, and Places for People will be delivering HOPES. So for any of those people, I'm putting in a little plug for any people who are clinicians at Places for People who might have folks that have schizophrenia and can really benefit from skills training and an approach that has a lot of evidence behind it to improve functioning and quality of life. We'll be launching that in the next probably month or so. Okay, so here's the list, which I've already kind of gone through. And so this is this we have developed now a whole set of curriculum and materials that include instructor guides. And I'll show you some examples. And the manuals are very scripted, and it was intentional from the beginning so that it would permit delivery by folks that don't necessarily have tremendous background in delivering these kinds of interventions, so that there's a script that one could read from. The text from all the handouts is woven into the instructor guides so that it makes it easier for the facilitator not to have to bounce back and forth between handouts and the guide. But the handouts are nice, very visually appealing printouts. They contain all the important elements of the skill, so the instructor can pretty much go over the handouts and be confident that they've covered the important elements. There's also a whole set of what we call community support sheets. These are one-page summaries of all of the skills that are taught that are meant to be distributed to people that we try to engage in the involvement of the HOPES participant to support and facilitate generalization of skills to the natural environment. And so there's summary sheets for that person who we try to bring in as kind of a partner. And all of these they're available for purchase, or if training is purchased, then the materials come along with that. And so each of those 8 topic areas has between 4 and 8 component skills within them. There's also a monthly meeting that occurs. So there's a group or individual setting in which the skills are taught. And then there's a monthly meeting to really focus on each person's personally meaningful goals, how things are going with acquisition of skills. We try to bring in the community support person to those meetings, but really to give more focused attention to the individual and make sure that progress is happening. In terms of the sessions, whether they're individual or group, this is kind of just a quick breakdown of how they play out. So there's kind of a welcome and a review of an agenda. There's review of action steps. We've kind of gotten away from calling them home practice. We don't call them homework, but action steps that people are working on from week to week. There's a brief review of the prior topic. And then we open up the discussion of a new topic, including drawing out from the group or the individual the rationale for learning the skill or topic, discussion of how the skill breaks down, and then a fair amount of time in the session is spent actually practicing with role play or some other kind of hands-on practice the skill that they're trying to learn. And then there's time at the end to plan an action step for the coming week. So that's kind of the way the sessions play out. Right now, we've been doing 90-minute sessions. That's in part because we've now switched everything, of course, to remote. And things take a little bit longer when you're gathering people into a remote group. But that's 90 minutes is pretty standard at this point. This is just a picture of the cover of the instructor's manual. And this is an example of one of the pages from the instructor's manual. So there's kind of a checklist at the beginning. There's blue text, which is sort of the script. And then the italics is kind of instructions of, what to do. And then the manual also, like I said, has the actual text from the handouts pasted in. But that's kind of the way it looks and how it's laid, so that the script really stands out as the blue text. This is just the cover of the set of participant handouts. So here's just an example of what the participant handout looks like. And you can see that, the little characters are older people, and they're colorful and engaging, and they don't have a ton of words on them because we didn't want it to be too text dense. That can be intimidating for folks. And so the facilitators invite group members to read from the handouts and then discuss what's written there. And they're usually only like 1 or 2, 3 at the most pages for each topic. So this is just another example of one of the handouts. This is a skill for sharing physical symptoms with a doctor. And so the skill is broken down into different steps. this is an example of a community support sheet. So this is where we've summarized a topic, and then at the bottom have some suggestions for how the community support person might be able to support the individual's use of the skill. And so HOPE starts with kind of an orientation session, either individually or it can be done in a group, where you go over some logistics and talk about the goal of HOPES, and really emphasize that it's about trying to help people live into a better life. And it sounds kind of corny, but that really is what it's about. It's, the idea of just learning new skills alone isn't as appealing as thinking, we want you to really feel like you're living into a better life. We want you to feel like you're getting what you want to get out of life. And so that's really at its core, and everything about the learning and the practicing and the weekly objectives, that all feeds into, what's important to you. What do you want to get out of life? How do you want your life to be different or better in some way? There's a session on kind of setting and achieving goals, because objective setting and really emphasizing and taking the time to help people set very specific objectives from week to week that are then revisited and reviewed and talked about is just a key part of both HOPES and IIMR, actually. So maybe I'll stop here just for a minute, because the next set of slides is kind of just giving you a quick walkthrough of the curriculum itself, so you can just see what's included in these interventions. But maybe I'll just stop for a second and see if there are any questions that have come up in the chat, or any questions people want to shout out.
Sarah, we had a question earlier. It was about CBSST. Is this a group intervention or not one-on-one?
It is a group intervention. Yes. Yep. Yeah, it is. Okay. Anything else right now, or should I?
That was the thing we had. But if people want to keep entering in the Q&A, we'll keep.
Yeah, and I'll just keep going.
Okay.
So this will just be kind of a walkthrough for people who are interested in knowing a little bit more specifically what is contained in these interventions. So I'll just kind of briefly go through the modules that are included in HOPES. So one module is about making the most of leisure time, and it really responds to the idea that a lot of older people with serious mental illness, even if they're not sort of like retirement age, they kind of often consider themselves retired and are not interested in competitive work, even if they're, at an age in their 50s or something, where ordinarily you might expect someone to, certainly still be working, but oftentimes they're folks that don't have a job history for a really long time, but they have a lot of time on their hands, and ought to be trying to feel like they're making productive use of that time. So there's we have this model called the 3 stages of fun, which involves first thinking about how to really savor the moment, mindfulness, enjoy leisure activities as they're happening, but then also, bring positive feelings back into the present by remembering things that were fun. And it doesn't have to be, reflecting way back on things from 20 years ago or 30 years ago that could be painful from, when their illness was maybe in a really bad place, but even just, something that happened a week ago that was really fun. I think we often don't capitalize enough and really kind of take advantage of the positive feelings that can happen just from thinking about things that were fun that happened recently. And then there's anticipation. A lot of times you get even more enjoyment out of planning something. You think about Christmas or a wedding or something like that. There's a lot of enjoyment that come from just looking forward to something fun, or even just looking forward to going out with a group of friends or something. And so we teach about that, and then we kind of talk about putting it all together. We focus on trying to encourage people to engage in leisure activities with other people. So the concept of inviting someone to share an activity and then planning for an outing. And so that's kind of what that module is all about. Then we have living well in the community. That's kind of another topic. And one thing I'll say about HOPES is that sets it apart from IIMR is that in HOPES, there's a real focus on positive functioning, on living your best life, on enhancing your overall quality of life. And it really doesn't mention mental illness at all. So it talks about physical health conditions and how that can interfere with your functioning and your ability to pursue goals and live the life you want to live. But it really does not, because we knew we had IMR already, and then we developed IIMR. That's the place where we talk more about illness self-management. So HOPES is really more, if the focus is on, all right, we want to get people to get excited about life and functioning better and living a better life. And the focus is really on wellness. We have a class that talks about technology. This is actually a class that we've recently updated because we have found that older people in particular, they may have smartphones and have access to technology, but are struggling with how to use them properly. So there's some really nice handouts that give people some basics about some of the more common apps and using a smartphone and so on. And then using the phone to get things done gets into more like text messaging and using Google Maps and things like that. We have a class that's totally devoted to using video calling. So it talks about Zoom and it could be applicable not only to medical appointments, but also if people want to use video calling to connect with their social supports. There's a whole class on that sort of addresses the problem of older people getting ripped off or taken advantage of by scams and things that come through the email or over the phone, and just how to navigate and make sure that you're not being ripped off, and how to navigate customer service. And when you call and you don't get a human being anymore, and that can be really frustrating to older people. There is a class on accessing public transportation, including using travel tools like Uber or apps and websites and how to get around. There's a class on getting important items that you need. So there's, a lot of older people don't feel comfortable with online shopping, even though a lot of times you can get better deals and things like that. Navigating these enormous stores that can be really intimidating and stuff like that. So those are some topics that are covered in that class. There's a class on making the most of your money that talks about things like online banking that may not be something that older people are doing. And it really focuses on, the population of people who probably have a small amount of expendable income at the end of all their bills. They're living on a fixed income. So that really is definitely the focus here. And then finally, there's a class on asking for help. We found that older people in particular are really sort of reticent about being a burden to other people and not wanting to ask for help or overwhelm other people, whether it's family members or neighbors. And so just talking about that topic and how to make positive requests and then offer to help others, because we found that, there are things, and people don't appreciate that there's things that they can offer, older people can offer, even if it's not, a ride to the store or something that involves, having money. It can be lending an ear. It can be, sharing a meal or something like that. So we talk about that. Okay, so then there's a whole module on communicating effectively. And this is really a lot of the kind of what you'd see in a basic social skills training course. So how to start up a conversation, brainstorming topics. There's, a lot of older people kind of hang in the background because either, they're not sure what to say, or maybe they have hearing problems, they're not catching it all. And so they figure, well, I just, won't contribute and I won't start up a conversation. So ideas for how to strike up a conversation, how to maintain a conversation by asking questions in particular, because that puts more of the onus on the other person, and it's easier to at least be engaged in conversation that way. Maintaining conversation by giving factual information, sticking with the topic. So this, sort of responds to the idea of people who may have thought disorder or get derailed easily, specific training on how to prevent that so that conversations are more successful. Self-disclosure is obviously, anyone who works with people with serious mental illness knows that that's an issue that has to be addressed sometimes in terms of protecting people from being embarrassed or taking advantage of, and the idea of high, low, medium self-disclosure and how to gauge when other people might be uncomfortable with level of disclosure. And then conflict resolution is a real area around social functioning and social interaction that can be problematic. So how to express negative feelings in a productive, effective way, how to think about other people's perspectives, how to manage feelings and reach solutions. And then we have a class on how to end a conversation smoothly, and then sort of how to put it all together. That's our communicating effectively module. Then we have a whole module on making and keeping friends. And so there's kind of the idea of what is a friend. A lot of times people with serious mental illness will think of paid treatment providers as friends, or, friendly people in their environment, like the waitress at the cafe who serves me coffee or something like that. So the idea of like, what do we mean when we say friendship? Where are places you could meet new people if you are short on friends, how to find common interests, how to then take the next step and, learn about another person. It sort of responds to the tendency of people with serious mental illness to kind of have an excessive self-focus. I'm convinced that one of the things that kind of cuts across, many serious or even not so serious mental illnesses, but excessive self-focus can be a really not a healthy thing, to kind of focus too much on what's going on, the bad things in one's life can cause a lot of distress. And that's true for, schizophrenia, depression, bipolar. So the idea of reaching out and thinking about wanting to learn about another person, giving and receiving compliments as something that can really enhance a friendship, negotiating a compromise. So the idea of helping people figure out different ways to meet in the middle if they're trying to establish a relationship and do activities with people. Reconnecting with old friends really kind of was specifically created with older people in mind who may have just lost touch with people, and we've kind of upgraded that class to talk about things like social media, safe ways to connect and find people that maybe, were good friends in the past, but you've lost contact with, and how to make another initial contact and maybe reignite, get some spark to those old friendships. And then responding to requests. This one sort of comes from what we've observed with some older people who have a hard time saying no, who feel like they get taken advantage of, who feel like they have to say yes to everyone that comes and asks them for money or whatever it is. So teaching people how to politely refuse requests. And then we have a module on healthy living. I mean, you could go for a year just teaching about healthy living. So these are all kind of, they're really just skimming off the surface of these different topics, but sleep is a huge one. And I think that it's under attended to in this population. So we did include that. We teach people about the major medical problems, things like diabetes and COPD and heart disease that are very prevalent in this population, and give people some self-management tips. There's a class on healthy diet and exercise. Again, that could be 10 classes. But it's some of the basics. There's a class on preventive healthcare. That's a big focus, again, for older people, making sure that they're getting the preventive healthcare that they need so that they will not end up with, cervical cancer, colon cancer, encouraging people to, get colonoscopies. And it was certainly harder for people to get the more invasive cancer screenings, but we were really successful in doing that with hopes by teaching people and helping them understand what's going to happen and how important it is. And then we have a topic on anxiety management. So specific techniques for kind of managing stress and anxiety. Again, not really placed in the framework of, I have this mental illness and I have this, but just, everybody gets stressed out. Everybody gets anxious about things. And these are some simple tools for how to manage it. Okay, then we have specific teaching on how to be a better consumer of healthcare, which is becoming more and more difficult in this country. And what we see is a lot of again, sort of, well-meaning professionals just sort of taking over. Well, I'll just make the appointment for you. And not probably enough emphasis on training people to take care of their health on their own, including things, even like preparing for a healthcare visit and really communicating health issues succinctly, since you only have a couple minutes with the actual doctor. And so really, what are the important things to note when you're talking to your doctor about physical symptoms, teaching people about how to be an active participant in discussing treatment options versus, the tendency of older people is, well, I got to defer to the doctor. I can't question anything the doctor says. I can't even really ask questions of the doctor. But then if I don't like what the doctor's telling me to do, I just won't do it. Versus engaging in an actual dialogue and feeling like you're on the level playing field, because, what we teach people is, you're the expert in yourself. And the best relationship with a doctor is one that's more in partnership. So that is something in particular that I think older people really need. So then we move on to using medications effectively. So we teach people, a lot of older people in our work, they're taking all kinds of medications and really don't have any clue what they are and what they're supposed to be doing. So we get a lot of I take this little blue one and then there's this big white one, and kind of not having maybe a vague sense, but not really understanding what these medications are and what they're supposed to be doing. And so there's a big focus on just folks need to at least know the basics around the major drug classes, knowing the names of the medications that they take themselves, training people to at least carry a list, even if they can't rattle off all the medications themselves. And then, teaching people about the importance of taking medication exactly as prescribed. Older people in particular have a tendency, to have poor adherence. It's not even intentional. They forget. And then there's this kind of mindset of the last thing I want to do is take too much. So if I can't remember if I took it, I just won't, I won't take, I'll refrain from taking this dose, which ends up that people are often way below the clinical threshold. And so we teach people about the fact that, drug companies, they do these studies to find out what the minimal dose is to achieve clinical benefit. So if you go below that, you're not really giving the medication a chance to work. And so why it's important to take every dose, exactly as it's prescribed, really because you want to know, is this working? Is it doing what it's supposed to be doing? And if it's not, in spite of the fact that I really, took it the way I was supposed to, what are we going to do about that? Are we going to try something else? I got to have a conversation now with my doctor. So it's not, when it says evaluate advantages and disadvantages, it's not so much just, should I not take medications at all, or should I take them? It's, how about this one? Is this working for me or not? And if it's not, then it's better to just put that out there with the doctor than just sort of not take it, but tell the doctor, oh yeah, I'm taking every dose. We have a whole class that goes over strategies for remembering to take medication. So a bunch of different sort of behavioral tailoring approaches, a class that's really specific about how to evaluate whether medications are working. And then we go on to intimacy and dating. This is our latest, greatest module that we created in response to really interest from the community, and people with serious mental illness were clamoring for this sort of a topic. And as we put it together, it started off really more like around dating. And then I felt like there's enough people that aren't interested in dating, maybe aren't interested in having a romantic partner, but the concept of having an intimate friendship, the concept of having at least some people in your circle that you feel you have an intimate relationship with is really important. And so we're careful in the beginning about defining what we mean by intimacy, that we don't just mean, romantic involvement, that we mean like feeling really close to someone, feeling like you can trust someone, feeling like, you can share with someone, that they'll understand you and be there for you. So it's kind of a mix of, you get people who are interested in dating that will be paying attention to certain things, but then it's still relevant for people who maybe aren't interested in dating, but would like to have more intimate relationships. So we talk about the benefits of having intimate relationships. We do spend a little bit of time kind of talking about sexual orientation, gender identity definitions, just to be inclusive and make sure that there's kind of a general acceptance of being open to everybody, and that we don't have folks insulting each other or anything like that, making disparaging comments. We talk about where would you find people if you just wanted to have closer relationships, or if you wanted to date. We talk about online dating, finding common interests, how to get to know someone better, whether it's, it's a prospective date or just someone that you want to get closer to. We have a class on handling rejection. So it talks about, what if you reach out and you're sort of rejected? How do you handle that? But also, how do you refuse an offer? Maybe someone asks you either for a date or wants to become closer to you and you're not interested. How do you let someone down gently? We do have a class that's specifically about sort of some date etiquette and things like that, how to keep the conversation going, proper self-disclosure, who pays and things like that. And then we talk about emotional intimacy, commitment, level of seriousness in relationships, how to handle jealousy. And we do have a class on sexual activity. It turns out that I actually did a study and published a paper on sexuality in people with serious mental illness. And, there's a lot of people who shy away from it. There's people with, certainly abuse histories who have no interest in sexual contact, but there's, having a sex drive is normal, and having a sex life is a normal part of being a healthy adult. And what we found in our study was that doctors don't tend to like to talk about it with their folks with serious mental illness, and people with serious mental illness, they have side effects of medications that affect their sexual functioning and abilities, and they feel nervous about bringing it up. And so it's about trying to teach people that, hey, this is like your physical body. The doctor has a physical body. It's just about the functioning of your body, and there shouldn't be any shame about discussing these kinds of things. Okay, so I'll pause there again, because that's kind of the end of the presentation on the HOPES curriculum.
So Sarah, we did have a couple questions come in, and if anybody has a question now on HOPES, add it, or you can add it later too, but
yes.
So someone was just double checking that right now HOPES is being offered both in person and virtually, correct?
Yes. Yep, that's right.
And then another person said they might have missed you saying this earlier, but really interested kind of in what prompted the development of the HOPES program, and any particular elements that you think were missing from other programs or approaches focused on older adults.
Yeah, what prompted it really was these studies in the late 90s showing that looked at nursing home placement for people with serious mental illness and institutionalization, and what was driving that. And it seemed to be, it was sort of lack of social skills and social support, lack of kind of independent living skills. So you had a lot of people who were older who I mean, so if you go back to the late 90s, this is really when you still had a fair number of people who with serious mental illness who had been potentially institutionalized, like in a hospital or these group homes where people don't have the ability to do a lot for themselves for years and years and years. It's sort of like use it or lose it, right? So they had lost these skills that they used to have for maintaining, our residents independently, like budgeting and, taking the bus and things like that. So there was this like area of deficit around sort of independent living. There's this area of deficit around social support and kind of social skills. And then for older people, the medical comorbidity and the lack of attention to physical illness was a huge predictor of why people with serious mental illness were ending up in a nursing home at age like 45. So that was actually our primary focus in coming up with this, because there were no interventions at that time that addressed, there were interventions that addressed, basic social skills and things like that, but there were not interventions that really addressed, that also incorporated training on how to, manage your physical health. If you're in this group of people who have a serious mental illness and have been institutionalized for a long time. And they just weren't tailored to older people. And I've been trying to kind of just make reference to some of the reasons why. So for example, like reconnecting with old friends, you won't find that in skills training for younger adults. That was really a nod to, okay, these are older people. So friendships are important, but they may have old friends that they haven't connected with in a long time. So a lot of the individual topics were things that, things like, older people having a hard time saying no or having a hard time asking for help. These were all things that we got input from the larger community of clinicians and people with serious mental illness and the research that we said, there really isn't anything that is tailored enough for this group. That being said, HOPES is something that has been appealing over the years to folks who provide services, not just to older people with serious mental illness, but also to younger people with serious mental illness. Some of the topics, particularly like the intimacy and dating and things like that. What we found is that, if it's a 25-year-old, they're pretty bored with this is your smartphone. This is how you use these apps. Those are really more geared towards older people who don't have those skills quite as polished as younger people. So there still are some skills that maintain that more like applicability to older people, but there just wasn't anything. That's kind of why we did it back then.
All right, we had a couple more questions come in. One, just
Sure.
a comment to say that they think it's great that that you added the intimacy and dating to the curriculum.
Oh, good. Awesome.
And then
People liked it. We've only, we only have a little bit of experience now because it just came on board, but the participants liked it. It went well. There was one of the group leaders was a little bit nervous about how explicit some of the language is, but there wasn't like giggling on the side or anything. Like people were mature adults about it. It was good.
That's awesome. And then two more questions. Have there been any adaptations to the program for virtual delivery, especially accounting for barriers that some older adults might have toward using the technology?
Yeah. We did kind of do a bit of an overhaul and we cut out some of the curriculum that felt a little repetitive. So we made it a little bit shorter because it is just harder to cover as much material, when you're doing a virtual group versus an in-person group. We did have to provide a lot of training up front on, because we felt like it was important in doing it virtually to have people on camera. We really didn't want to just have people on a telephone and just kind of have voices on your phone versus actually being able to at least see people when they're speaking. And a lot of people are just using a smartphone, and so they don't, like I can, we can see the panel on our laptops, and so you can see everybody at the same time. But yeah, we have had to provide a fair amount of training and in some cases technology support to folks. But I would say by and large, we haven't had to change it that much. It's kind of worked remotely. It's gone pretty well.
That's cool. And then one more question that's not necessarily so much hope specific, but just saying, what are we seeing since the pandemic? Are more adults, are there more adults that stopped taking their medications and have maybe increase in psychotic symptoms or losing their housing? Have you noticed any of that sort of stuff? Maybe
that's a really good question. I mean, and I'm not sure how much published information is out there about that. There's a lot of, if you kind of look this up, because I'm working actually just as a sidebar, I developed a 3-session sort of COVID education and coaching intervention for people with serious mental illness to try and help them avoid catching and spreading COVID, because what we know is that if you have schizophrenia in particular, you're much more likely to die from COVID than if you do not have schizophrenia, or if you do not have a mental illness as well, I should say. So we know that people with mental illness are more vulnerable to COVID. There's lots of published papers that speculate about things like that. But it's, and if you read the title of the article, it looks like you're going to find data, but then what you find out is that you don't. It's sort of like really smart people opining about why it might be that that there's this greater level of risk. But I don't think that there's a lot of published work out there yet about things that specific. I can say that, I mean, we've felt like people are using substances more, and we literally heard people say things like, I am so anxious about all this, I started drinking again. We've seen people that have been working on smoking cessation go back to smoking because it's such a reliable, effective coping strategy. So we've heard from the community, from peer support specialists, as well as people with lived experience, that they feel like they had taken one step forward before the pandemic, and now it's 2 steps back in terms of feeling really isolated. It's interesting. I mean, people with serious mental illness really hunkered down. They knew how to hunker down. I mean, that's what we heard from them. They said to us, yeah, we knew better than anybody how to isolate at home. And so we just went right into that mode, and peer support workers who work with them feel like, oh, here I had them almost, out there and in the community and making strides, and then everybody went home. That's just what everybody did. So, but specifics around things like medication adherence and symptoms, there just isn't a lot of data yet that's available on that. So I'm not sure.
Yeah, thank you, Sarah. Those are all the questions we have right now. Thanks.
All right, so I'm just going to do a quick time check. And I should probably stop talking and leave how much, like at least 15 minutes at the end, or more than that?
I think 15 is good. I don't know if Kara or Nathan, you have any other thoughts, but that sounds good.
Sounds good.
Okay. All right. So I'll quickly run through the Integrated Illness Management and Recovery, IIMR program. So this is our other program that's focused on teaching people skills for managing both psychiatric and physical illness. It's based on and adapted from IMR, which is Illness Management and Recovery. It can also be delivered either in group or individually for anywhere from, I would say, 4 to 10 months. 3 is a little too quick. There are 10 separate topics. They don't all have to be taught. I mean, really, HOPES was also set up in a way that, we are studying it in our research as a complete package. But when I developed all of the modules, they really are standalones. So you could just deliver one of them or two of them or three of them, depending on the need of your population. So you don't have to deliver the entire, 48 weeks of curriculum. Or in this case, you can do it in a little bit less than that. So, and similarly to HOPES, it's about really, encouraging people to think about what they're about, recovery, about wellness, about what they want to get out of life, and all of what they learn about illness self-management is in the service of that goal. So just a little bit on the history. So there was actually a specific request for proposals that went out in 2004. It was jointly put out by the Substance Abuse and Mental Health Services Administration, SAMHSA, and the National Institute of Mental Health, and NIMH. And it was specifically like, we want to get proposals that talk about adapting evidence-based practices for older people. So, why did we develop HOPES? I mean, there really was this groundswell around like, oh, we need to do something about this. The population's aging. We don't really have interventions that have been adapted for older people. We need to develop them. So that was really kind of what sparked our work in adapting IMR. And we did a couple pilot studies. We evaluated IMR in a larger study that was funded by Medicaid in Boston, a health home project in Maryland. In 2014, we did kind of a major revision of IMR because I got involved in 2009 in SAMHSA's PBHCI, which is the Primary Behavioral Healthcare Integration Program. People may have heard of that and may have funding from that program. And the goal of that program really was to integrate physical health care into the community mental health care setting for people with serious mental illness. And a lot of those programs have achieved co-location. They haven't really quite achieved full integration. Full integration is really hard, and co-location is great. So I don't mean to suggest that that's not a good outcome, but I thought about the IIMR curriculum. I said, this looks kind of like co-location. It was sort of like, oh, here's all your skills for managing your psychiatric illness, and over here is your skills for managing your physical illness. And so we really took time to carefully overhaul the whole curriculum and make a new version where, and I think it really is truly the only curriculum out there for people with serious mental illness that is just fully integrated at every step of the way. It's all about integration and how one affects the other in terms of mental health and physical health. And so we studied this in a large randomized controlled trial in Boston that enrolled 300 people. And I have a large study that will enroll 600 people ultimately, that's comparing this intervention to the chronic disease self-management program, which is more of a generic medical illness self-management program, 6-session, developed by Kate Lorig. And we have a couple sites in Kentucky and Tennessee, and we'll see what happens. But IMR has been implemented in at least 10 states. This is kind of the list of the curriculum, and there's actually 10 topics, but it numbered 8. Topic 8 got numbered twice. So there's kind of the idea of recovery. There's a module on the brain-body connection. Then there's a bunch of handouts, and I'll show you some of this on physical and mental health, sort of education. And you can see there's some overlap with HOPES. There's a healthy lifestyle module. There's a using medications effectively module. There's a social support, managing stress, managing symptoms, relapse prevention, and then getting your needs met in the healthcare system. But there's definitely more of an emphasis on illness self-management versus it's in the service of, people's personally meaningful goals and recovery, but it's there's not as much of a focus on things like basic social skills, independent living skills, leisure skills, things like that. There's a practitioner guideline for each session that talks about what to emphasize in sessions, specific suggestions for how to discuss the topic, suggested additional resources. It's not scripted the way HOPES is. The guidelines really are just like a couple of pages for the practitioner, the facilitator, to prepare for each session. And the sessions, as in hopes, really rely on the participant handouts. So all the meat of the session, the content is contained in the handout, because what we found was that it makes it easier for the person delivering the intervention. Everybody's got the handout anyway, and that's where the material is. And then there's kind of an action step sheet, because there's also this focus on weekly steps towards goals. And so really there's just this constant, deliberate, repeated efforts to connect physical and mental health. It's definitely rooted in, recovery-oriented treatment, emphasizing, autonomy and mastery over symptoms in order to pursue meaningful life goals. So that's a big piece of it. The structure of the sessions are kind of similar to HOPES. There's an agenda, there's a review of action steps, there's a review of the previous topic, there's establishing rationale for the new topic, engaging people in materials, doing role plays and practicing the skill, and then developing an action plan afterwards. That's either geared towards what was talked about in terms of the skill or their personally meaningful goals. This is an example of the handout for the topic on the brain-body connection. And so you can see, again, not a huge amount of text. Each handout is just a few pages. And there's little discussion points. You can see where it says, let's discuss, and there's some questions. So again, the instructor, the facilitator doesn't have to flip back and forth between, her guide and this handout. They're just, the discussion questions are contained in the handout. This is one of the handouts that has the education about a medical illness, so diabetes, for example. And so, these all start with sort of, what do you know already? Getting a discussion, what's it been like to live with diabetes? How has that affected you? And then like really simple basics on what diabetes is, how it works, how you need to manage it. We got a lot of pushback with IIMR early on, because this material is delivered by a non-medical professional. And we got a lot of sort of like, oh, it's outside my scope of practice. And, I don't feel qualified to provide this kind of education. And I really pushed back and said, well, but the fact of the matter is we expect our clients to learn these basics. They need to learn these basics to take care of themselves better, to understand how the illness works, and therefore address it in the right ways. So I feel like it's incumbent upon us to at least be able to learn those basics, the same basics that we want our clients to learn. We certainly don't have to put ourselves out there as medical experts in delivering this material, but if we expect our clients to know the basics, I think it's incumbent upon us to learn the basics. This is just a little sheet that people can fill out in terms of action steps, a little action planning sheet. And then, so here are the topics. So recovery, the main thrust of this is to talk to people about, what does recovery mean? A lot of times people associate recovery with substance abuse. And so the idea that that's not really how we're using the word, and really giving people permission to kind of dream big and think about ways in which they'd like their life to be better. Then we move right into the mind-body connection and the idea of identifying the quote source of the problem. So, many times as mental health practitioners, we're misidentifying problems. So you might come in and someone seems really irritable and oh man, George was having a bad day today. Well, if we had thought to ask George to take his blood sugar, we would have seen that it was, 35. And it's like, oh, that's why he was irritable. and people with these conditions don't often know that, something like irritability, it could be from my mental illness. It could be from my physical illness. Even someone with very severe depression, you see the commercials on TV, it can cause physical pain. And so it's like, oh, I'm going to all these medical doctors trying to figure out my physical pain. Maybe it's the depression. So really getting people to think about the fact that if you don't identify the source, if you don't figure out, like, is this really is the root of the problem more in my physical body or my mental health, I'm not going to be able to take the steps that I need to address it. Even though, one can then kick off the other and you can get into a spiral. It's kind of like, how do I, peel the onion layers back and figure out what's really driving this from the beginning? And so then, talking about biological factors that, sometimes you can't change. And obviously things like age and race and gender can be risk factors for different illnesses, but how we can address those using medications or health practices. And then, things, stress and environmental factors. So the idea of the stress vulnerability and how there's the biological piece and then the external stress piece. We have a whole array of handouts that provide education. So these are the mental illnesses that we have handouts on because they are the most common and prevalent in community mental health centers. And each of the educational sheets starts off with, what do you already know about this? What are the most common signs and symptoms? What other problems are associated with this? How does, schizophrenia, for example, affect physical health? How does diabetes affect mental health? So we put sections like that in each one of these handouts. What steps can you take to manage it? So it's people get used to this structure of how they're going to tackle each one of these topics. This is a list of, I think we may have a couple of other ones. I think we just recently developed a chronic pain handout. We try to respond to our partners who tell us, you got to have, I think we now have a hepatitis handout. You got to have this, you got to have that. But so a whole array of handouts that give education about a variety of medical illnesses. And, of course, you pick and choose which ones are relevant for either your group or your individual. You don't cover them all. We have a module on healthy lifestyle. And again, it's sort of, it could go on, and it's just the basics. But we have a whole, actually, couple page handout on tobacco smoking that really provides good education about how tobacco affects the body, like what is CO, and, isn't a sort of you should quit kind of approach, but just more of a, here's what you might want to know about it. Okay, so then we have our using medications effectively. It's sort of similar to the HOPES approach of knowing what you're taking, getting some education about the benefits and side effects, exploring whether they're working or not working, and behavioral tailoring around making sure you're taking your medication so you can at least find out if they're working. Social support. This one is a little bit different. We don't quite have something like this in HOPES. In HOPES, we have, making and keeping friends, but this is more geared towards, why is social support so important in terms of our health, whether it's our mental health or physical health. And not just as a fact, there may be, we encounter people in some of these programs who aren't really that jazzed about being socially connected, but the research shows that, if you have social support, you're healthier. So just sort of putting that out there and then letting people make up their minds. Managing stress. So this one, we attempt to provide people with a lot of really easy strategies to manage stress and anxiety, even things as basic as finger tapping, things that people, breathing exercises, things that people can do really easily. Because if you don't, in my experience over these past many years, if we don't impart really simple things that people can access wherever they are, whenever they're needing them, then it doesn't work very well. And really encouraging people to practice these when they're not stressed so that they'll be accessible when they are. That's a big focus there. We talk about managing persistent physical and mental health symptoms, acknowledge that some symptoms are just persistent and we're not going to eliminate them completely, but the idea of, how can we live our lives in spite of them and not let them overcome us? And then relapse prevention, both in the context of a psychiatric relapse, but also you can certainly have relapse of a medical condition and they can affect each other. Oftentimes, when people have a relapse of a medical condition, they, psychologically, psychiatrically, it's really hard to manage. And so one can trigger the other and you can be into a spiral. So a lot of this is classic, early warning sign, relapse prevention plan type stuff, but then, woven into that is the piece around the physical health. And then the last topic has a lot of stuff in it. It's, we have curriculum around finding a doctor if you don't have one, or if you're not satisfied with the doctor that you have, more than just like, throwing a dart at the phone book, getting healthcare or services for specific problems. The making appointments and preparing is sort of similar to what you'll find in HOPES, and sharing information, advocating, but this piece about making decisions about when and where to seek care. So one thing that was true in our early studies of older people is there's this kind of like impulse to go to the hospital, go to the emergency room. I see this in my mom too, who's now 80. There's this like, oh, something isn't right, I better rush off to the hospital, and so educating people about when it's appropriate to go to the hospital, when you can just call your doctor, and a nurse can call you back and talk to you and figure out what's going on and then make a more informed decision. We had a lot of people in our early studies who sort of didn't know that even though the doctor's office is closed on the weekend, you can call and someone will call you back and you can have a conversation. You don't have to rush off. And even if you do need the emergency room, you don't necessarily have to call an ambulance. You might have a neighbor that could take you because you're not in a situation where you're stopped breathing or, so that was really responding to what we saw as a lot of unnecessary use of very expensive healthcare, like emergency room and hospital care. We focus on preventive healthcare and then sort of resources for building a healthy lifestyle, like, where can you access exercise? Where can you access information about healthy eating and things like that? And then let me see, I'm just checking the time. All right, I'll just like really quickly fly through the main results of our studies. So in HOPES, so the blue is HOPES, the red is the comparison group, which just got their usual care. You can see that that in terms of the percentage of preventive health targets received, very quickly at 12 and even 24 months, people in HOPES were getting much more of their preventive health care. But then so I didn't say this earlier, but between 12 and 24 months, people in HOPES in this study came in for like monthly booster sessions. And then after 24 months, there was no more HOPES sessions. So between 24 and 36, there's no intervention. You can see that these older people really kind of needed someone to be helping them take care of getting these preventive health targets, because they sort of regress back to baseline at 36 months. This is a measure of overall community functioning. And you can see that people in HOPES, have improvements at 12, and they actually continue to improve at 24 and 36 and at a much faster rate than the comparison group. In terms of negative symptoms, people in HOPES showed greater decreases in negative symptoms, that's hard to achieve. But I think it was a lot of the sort of activation and taking charge of your life and encouraging people to set objectives and be more active in their lives. People in HOPES achieved greater independent living skills that really persisted throughout the 3-year assessment period. This social functioning scale, lower scores are better, and so you can see that HOPES improved more. The kind of, the directions are the same, but HOPES has a greater, steeper slope in terms of their change. We had a big focus on advanced directives, making sure that every person had advanced directives in place. And so if you don't do that, then you end up with about 1/3 of people making it happen. And if you really focus on it and help people and teach them how to do it, you get twice as many people to establish an advanced directive. So, okay, let me keep going. So in terms of IIMR, primary finding was that, reduction in hospitalization at baseline. Interestingly, randomization didn't really work. And a lot more people in the IIMR group had hospitalizations in the prior year, but you can see they go down to 0 during the 12-month intervention. And then there's a bounce back after the intervention is withdrawn at 10 months. But, the folks in the usual care group actually increased in the number of hospitalizations. So we do feel like this is good evidence that people in IMR were really taking care of themselves better and avoiding probably that 25% for the control group. A lot of those are probably unnecessary hospitalizations. We also saw improvements in knowledge of symptoms and coping and medication management skills, relapse planning, managing symptoms, and really participating in healthcare decision-making, which was nice. And some trends around better diabetes self-management. It was kind of a smaller group. Okay, so then last but not least, I wanted to point people's attention to another resource in case people weren't aware of this, and some people may be. This E4 Center of Excellence for Behavioral Health Disparities in Aging. And the 4 E's are engage, empower, and educate healthcare providers and community-based organizations for equity in behavioral health for older adults and their families in the US. So it's an initiative across different entities, including SAMHSA and Rush. And their mission is to develop knowledge and skills in the healthcare workforce around aging, to build partnerships so that care can be more integrated for older people, to really get the word out about evidence-based programs and how to make sure people are using them, and to create a whole set of resources that older adults and their families can use. And so they have a website, e4center.org. And these are kind of their stated priorities to reduce behavioral health disparities. So they're focused on low SES and ethnic and racial minorities, depression and suicide is a focus, substance use disorders, physical health, and serious mental illness is kind of a more recent focus, but that's a definite focus they've taken on. So they have like webinars and workshops. There's these policy academies. Some of these things can be viewed on demand. Some of them you can attend live. And there's technical assistance available to implement evidence-based practices. And they also have this online certificate program. And this is like a 14-hour program, and it's geared towards licensed mental health clinicians, but teaches people about all these different topics, attitudes about older adults and aging, adult development, depression, suicide, so on and so forth. They have didactics, they have videos, case vignettes, and so you can achieve this certificate in older adult mental health competencies. So I wanted to bring that, and that's also on the E4 Center of Excellence web page. So thank you for your attendance. Thank you for listening. If there are any other questions or comments, I think I just made it under the wire there. We've got a little bit more than 15 minutes.
Yeah, I don't see any questions yet, but if you do, I had a couple questions that I'll ask you, Sarah.
Yeah,
so, if people are already trained in and experienced in delivering IMR, how big of a leap do you feel like it is for them to be able to pick up and learn? How much more training, or would they need to be able to do IIMR?
Yeah, that's a great question. I think that if people really have been using it regularly and have good skills, then it's not a huge leap to use. I mean, the topics are almost all like pretty much identical. The materials, the handouts will look very different. The materials for IMR, they're a little more like text heavy and they're longer. And I mean, we feel like these are a little more appealing to participants because they're shorter and a little more engaging. But it's the same basic approach, it's kind of like, here's the topic, let's engage with it. Let's see what it says on this handout and read it and discuss it. And so if you're a really good IMR facilitator, then yeah, it's not a huge leap. It's kind of like getting familiar with this new set of materials.
Right.
Yeah.
Awesome. I have another question.
Sure.
I just wondered your thoughts on if like an agency is, hearing this and they're first deciding like, oh, we need to have more programming for some of our older adult clients. How would you, what would be your advice on how they would decide like where to start? Like, oh, do we start with HOPES? Do we start with IMR? Like, what are your thoughts on how they could decide between what program to start with if they're like not doing specific older adult programming yet?
Yeah, I mean, honestly, I'm big on like asking the people what they want, so I mean, to me, it's kind of like we can sit here and decide what we think is best for the population that we serve, but how about asking them what they want? I mean, that's how that whole intimacy and dating module cropped up, was like, this is what people wanted. And so if people feel like, I really wish that, my medical conditions are really bogging me down, and I would like to have more help learning about them and learning how to manage them. And one of the things that we did before we created, not to bring in a whole different intervention, but our COVID intervention, we asked people like, what would be helpful? What would you want if this was about kind of education and coaching? And people said, we just want like basic education about things like, what is a virus anyway? Everyone hears the word virus, but like if you walk down the street in New York City and said, hey, define what's a virus, you might get all kinds of people going, I know what it is, but I don't think I can really articulate it, and so people wanted just like basic foundational education. And people love, I think, learning about the basics around things like diabetes. I mean, it sounds like it could be boring, but it's like doctors don't have time to sit down and teach people about stuff like that. So, but I kind of think it depends on what your consumers want. Is that what they want? Or are they more interested in, learning how to have better friendships, or learning how to, feel like they're making more productive use of their time? I mean, again, the thing about HOPES in particular is that each of the modules is like a set of component skills, and they're all meant to be standalone. So one does not depend on the other. You could pick and choose from any of those and like run a class on, making the most of your medications. And it could just be a quick, short, 4 or 5 week course. Or you could run the whole thing. I mean, there's really a lot of freedom there. The IMR is a little bit more like each module, so to speak, is really just like one handout. It's something that can be delivered in one session. It's tight, so it's if you have the freedom, it's good if you have a couple sessions for each topic. But and there's a ton of education about illness that's really cool. But again, so it kind of depends on like what you feel like your audience wants. What you feel like their need is. I mean, certainly, it can be a shared decision-making process of the, clinicians and deciding like, these are what we see as the biggest problems. But, you want people to show up, you better pick something they think they want to have.
And another person asked about HOPES and sort of that decision to not have an explicit focus of like SMI as part of HOPES. And so, kind of like how does the intervention accommodate SMI and, that not real focus on it. Yeah.
Yes. And it's not to say that when you run a HOPES class, and we don't really use the word group, because again, it's skills. It's about taking a course. People get a certificate at the end if they finish the training, and we call it training. We call it teaching. We call it classes, because it's just more appealing for people to feel like they're learning something that they're going to then use in the future. But it's not like people who do the class don't all know that everybody else sitting in the room gets services at the mental health center. And it's not that, nobody ever reveals, what diagnosis they have. And it's not that we have an approach of like, you should be, don't tell anybody, or, the self-disclosure thing is really interesting because on the one hand, I feel like, it's important not to give too much really super personal information about yourself to someone too quickly. But I don't ascribe to the idea that, oh, don't ever tell anyone that, you struggle with a mental health condition, because I think that just serves to reinforce stigma that, there's something wrong with having a mental health challenge, and there isn't. There isn't any more than having a physical health challenge. So, and the same kinds of issues that go into running any kind of a program like this, will come up in HOPE. So you'll have, we talk about challenges of like, some of the group members maybe are less adept and have lower level of functioning and cognitive struggles and things like that. And so all of those kind of issues you are dealing with when you're delivering this, it was this conscious decision, like we wanted it to be an experience where people came in feeling like what we want for you is for you to live your best life. And it's not about your mental illness. It's about like, what do you want to get? What's important to you in life? Oh, you want to, spend more time with your grandkids and be able to play with them, but you're in terrible shape, or you just don't know how to get yourself out of the house, or, and so the mental illness, people might talk that they might reference their mental illness, but it's just like the focus is on positive functioning, health, wellness. It's not on illness. So you won't really find references. You won't find the word schizophrenia in the materials. It just isn't in there because the focus is on wellness. But it doesn't mean that you draw this line, right? Because we're all about the fact that it all has to, it all mixes together, and they're inextricable. And anybody who thinks they don't have any mental health challenges is just fooling themselves. And I say that all the time. Anyone who thinks they don't have mental health is just fooling themselves.
Yeah.
We all do.
Hey, Sarah, this is Nathan. And real quick, I just
Yeah.
had a question about the feasibility of implementing HOPES or IMR and outside of a community mental health setting. Like, would it be feasible to implement this within like an area agency on aging or other agency provider?
Yeah. I mean, we ran the HOPES classes at a senior center. I mean, it was led by people who were employees of the mental health center. And we had another class like at a function room in a public library. Like, we like the idea actually of holding the meetings in a community location, because again, it takes it away from like, you're all here because you have a mental health challenge. So, I mean, I think that, but once you move it out of a setting where, you're taking care of people and helping people who have a lot of functional impairments and disability due to their mental health challenges, and bring it someplace where there might be, people that struggle with friendships, but they don't have a diagnosed mental health challenge, or it can get a little bit tricky, because I think that the level of functional impairment tends to be less in those settings, perhaps, than, you know what I'm saying, than in the mental health setting. But some of the skills are really relevant. So I think it'd be great.
Another question popped up. So piggybacking on Nathan's question, could HOPES be done in an inpatient setting, possibly maximum security, maybe with some adaptations made?
Yeah, we did a pilot study of HOPES in a nursing home that is a nursing home it was a nursing home in New Hampshire that specifically is for people with serious mental illness. And so, yes, there was, we didn't create like an adapted version of it because we didn't really have time to do that. But the idea was like, what if you could, really train people up, especially in some of the things like that would help them with a transition. these were people who were wanting to transition out of the nursing home back into the community. And it was like, what if you could arm them with some of these independent living skills and social skills and, get them some of these functional skills that they really would need to do better once you transition them. Because there was actually a whole, oh gosh, New Hampshire got in big trouble because they were, there was this whole, legal situation where they were housing people who just shouldn't be there. They shouldn't be in nursing homes and institutional settings. And there was really a ton of pressure in New Hampshire to do something about that. And part of the problem was just not having housing. But anyway, we did that. And people showed up and people liked it and it worked. So yeah, I think it could be done on a broader scale. We kind of didn't really follow up with a larger study, but if there was interest, I would definitely think that it would be a good thing. Yeah, it could be done.
Thank you. That's the last question we have right now. Oh, one more just popped up. How do you sign up for HOPES classes, and can our older adult group to get involved? How many older adults complete the courses? So I guess really the question is how organizations might sign up people to get trained. Mm-hmm. Because the idea would be then that you would run the group within your organization.
That's right. Yeah. So, we would train myself and a colleague, do trainings, and we now that do them remotely, reluctantly. I love doing trainings in person, but we had to realize that the world had shifted and we needed to keep things going. So we can now do remote trainings, which is good. It makes it easier for agencies not to have to pay expenses of travel and stuff like that. I should have included the link to. I actually have a website for my research center that has some information, but I mean, people can reach out to me at Dartmouth. So.
Okay. And I don't remember, because we sent a PDF of the handouts. Is on a beginning slide, did you have your contact?
I didn't, but I can.
If you give that to us, I think we can email that out to everybody because we have the email list.
Yep. And Nathan has my email. People can just reach out to me on my email and I will get back to them. And usually I like to kind of have a conversation, see what the need is, and if it seems feasible that there are people that can be trained and stuff like that, and then we can just go from there.
Thank you.
Yeah.
So I don't know, Nathan or Kizzy, Kara, anybody want to wrap up?
Yeah, I thought we had either Kizzy or Kara with some upcoming events.
You got it, Kara, or you want me to post?
I think Kizzy has them, but I just wanted to say thank you so much, Sarah, before we get off here, that we really appreciated all that you share with us. And I really appreciated all of the questions that everybody was putting forward today. That was really engaging.
Yeah, thank you for inviting me. And we had a couple delays, so I apologize if there were people that were geared up to see this talk a while back and then we had to push it off. So thank you for your patience.
And so I think Kizzy just has some of our upcoming trainings for individuals who are interested in learning more from Illume.
I can unmute myself, you all can hear me. So we have a motivational interviewing training coming up tomorrow. We also have our fall subscription that has launched. If you want to be on our email, if you want to reach out to me, I can add you onto our contact list to make sure that you get that information. There's a list of the other trainings, the understanding trauma and creating culture, creating trauma informed cultures. That one is on the 25th. The pricing and everything for each training is going to be on the website, which is on the PFP webpage. If you have any questions about any of the trainings, you can always reach out to me or Kara, Julie, Nathan, and we'll get back to you on information about those. Also, once you click off of the Zoom, you should see a link for the survey that should pop up. I'll also probably send a follow-up email with that link as well to make sure that everyone gets it. And I see there's a last minute Q&A that just popped up. I'm sorry, not a Q&A, but a request. So I will copy that and add that on to the next links. Again, we want to thank you all for attending this webinar. And if anyone else has anything to say, if not, we are going to sign off.
And someone just asked if the PowerPoint is available, and that has been emailed out. So if you attended, you should get the PowerPoint.
All right. Thank you so much, Sarah. That was wonderful.
Yeah, you're welcome. Thank you.
Thanks, Sarah. Talk to you soon.
All right. Bye.
Bye.
Bye.